Please start. We are live.
So
Good
over to you,
evening.
Dr. Vamshi sir. Yeah.
Good evening, everyone. Today we are doing the day 2 of the ASCO GI revisiting, and today we'll be starting off with the colorectal session to be done by Dr. Anant, and he has his panelists as Dr. Bhavna Sirohi ma'am, Dr. Smita Kanyal from JIPMER, and Dr. Akhil from TMH Varanasi. So over to you, Anant.
Thanks, Vamshi. Thank you and the entire team for having me here. So these are the five nicely named studies that I will be discussing over the course of the next 40 minutes. All of them have fancy names. Some of them have some fancy results as well. So what I'll be doing is the general format of the discussion will be that I will try and capture the major highlights of the studies, and then we can discuss pros and cons, taking opinions from everyone on the panel. And anyone of the panel who wants to make a point, please go ahead. Feel free to butt in. So I'll start with what I thought was the nicest of the studies of the lot. So this is low dose aspirin reducing the rate of recurrence in patients who have PIK3 mutations. This is called the Alaska trial. And this goes back to data published almost beyond a decade back when investigators from Dana-Farber and Japan figured that aspirin by inhibiting COX-2 probably lifts the blockade by PIK3CA mutations and ensures survival in colorectal cancers. They took the basic idea from there. This was a retrospective analysis of almost 1,000 patients. And then they formed the Alaska trial. So what the Alaska trial did is screen 3,500 patients, of whom 1,000 patients ended up, a little more than 1,000 patients ended up having mutations in the PIK3CA pathway, as well as PTEN and other members of the PIK3CA pathway. And around 60% of them came onto trial. And they were randomized between 160 mg of aspirin for 3 years versus placebo. Now, the primary endpoint was analyzed only in the PIK3CA mutants, but other secondary endpoints also included evaluation outcomes in those patients who had other mutations on the PIK3 pathway. Few key points: it had both rectal and colon cancer patients. 24% of all rectal cancer patients had stage 1 disease, and 50% of patients received adjuvant, and the median age of the study was the 7th decade. Coming to the results, the graph on the left is the primary endpoint of the study, which was cumulative incidence of CRC recurrence. Now, important thing to note is the actual number of events is very low. If you see in the aspirin arm, overall there were just 35 events in 300 patients. So, which means this is a cohort of cancers which is overall pretty early cancers. And clearly the use of aspirin decreased the cumulative CRC recurrence rate, even in the non-PIK3CA mutants, but others along the pathway, there was a similar increase in number of CRC events. In terms of DFS events, in the PIK3CA cohort, there was a difference, but it did not reach statistical significance. The p-value was only 0.091. But in other patients who have mutations in other members of the PIK3 pathway, it remains significant. And the difference in 3-year DFS is more than 10%, which is quite a lot. The worry in such an older population is bleeding, and 3 patients did have assays leading to death in the aspirin arm, and there was an increased incidence of post-op complications, DVT, and embolism in the aspirin arm. So, but I don't know whether they are significant because that was not there in the slide set, but these were increased. So, this is the basic idea of the trial, and I mean, now I'll start off with Bhavna ma'am. These are the 4 questions I had. Compared to existing data and biological rationale, do you think this is good data?
Yeah, I think it's very exciting data because this is a drug which is, which is easily available. And I mean, I would say 50 to 60% of our patients with cardiac risk factors are using it. The biological rationale, maybe not so much, but the data, I mean, there was definitely a decreased risk of those developing colon cancer. There were decreased number of polyps. And the dose of aspirin was 300 milligram. You know,
160.
160. It was even better. I mean, the CAP trials had 600 milligram and, you know, GI bleeds and all of those side effects were there. And they were the first ones to show that in Lynch syndrome, aspirin does work. But then you had the ASCOLT, was it the ASCOLT trial, which was negative?
Yes.
It showed in colorectal cancers. But I think this is just looking at PIK3CA mutation. And I remember discussing this almost 2012-13. There was another study which showed that, yes, it does work. So yes, I think the data is quite good, and I see it as practice changing because, you know, this is something which is easily implementable on a Monday morning clinic with not too many side effects at that dose. I don't think we can get 160 milligram in India, but maybe 275 milligram tablets should do the trick.
So Akhil, your thoughts on this?
Yes, sir. I completely agree with ma'am. If I was just searching on the internet about the biological rationale, I found that 2012 article of NEJM where it was shown that aspirin can directly inhibit PTGS2 enzyme, which is definitely a pathway for PIK3CA.
Yeah,
So
so
this is
PTGS2 is a fancy name for COX2. I mean, it's the
Yes.
same thing. So,
Yes.
you know, there is some rationale to it. So,
Correct.
are you, I mean, this is potentially affects 1/3 of your patients, you
Correct,
know.
sir.
So, I think the rationale is thereabouts.
Yes, sir.
You know, so would you start doing PIK3CA mutations in your early stage CRCs, let's say from next week, okay?
Uh, from a Monday morning, whether it can be implemented or not, I'm not very sure. But still, we know that PIK3CA patients have poorer outcomes. It's a poor prognostic group. And also, sir, we did our study where we found that PIK3CA is a very important mutation in our patients as well. It is not like that in Western population it is high and in us it is low. It's actually we have more PIK3CA incidence as we publish our own data from TMH Mumbai. So I think PIK3CA mutation we know prognosis is poorer. If we have some mechanism, this is a drug which is very cheap, 275 milligram tablets easily available everywhere. It makes sense to utilize it, but I definitely we need more discussions and some better follow-up might be always better because only thing worry is about the complications of severe bleeding and death, but that can always occur. But the good point is that as compared to CAP2 trial, because we were fond of CAP2 trial, since we test, I'm very fond of genetic testing and we conduct clinic at our center very regularly. We found we have around more than 30 patients of Lynch syndrome identified at our center already within last 2 years. So it's Lynch syndrome is also very common. But the problem is that CAP2 trial utilized doses of 600 milligram, which is definitely difficult to be utilized in the real world practice. But this trial had a very practical doses which can be considered.
So, despite your reasoning, are you going to use it on Monday morning or not? You see, it's a cheap drug. You have a good 600 patient study. In a 7-decade population, your incidence of side effects is low. So, what's stopping you?
It can be utilized, sir. I think we can go ahead with
Only
PIK3CA
problem,
testing is
you
not
know, I
difficult.
have is, see, MSI testing we now do in every patient.
Yeah.
We have kind of cost optimized that, kind of. Now, PIK3CA testing, how are you going to do it? The methodology, the cost, the testing, that is my concern.
So,
PIK3CA
Dr.
testing
Smita,
is available in-house at a cost of around 3,500.
no, Akhil, the question is, I think what Madam's point is that some genomic markers, you have a short panel. Are you going
Yes.
to add on the cost of PIK3CA2 for this reason? I think that's what she was getting at. And that's a fair point. That was my thingy also. Dr. Smita, your thoughts? Dr. Smita, you're muted.
Unmuted.
Am I audible now?
Yes.
I agree with Madam Dr. Bhavana and Dr. Akhil also that this is practice changing. a cheap drug, easy doses, significant benefit, I'll take it a step forward that rather than only doing it for PIK3CA, we can do it for all patients. Like instead of making it cost effective. And there's another ongoing study which is add aspirin trial. Maybe we'll get results in some couple of years. It has 4 populations, including colorectal, prostate, breast, where aspirin is added as an adjuvant treatment after completing all the other chemotherapy. So maybe that data supports the use of aspirin. There is no molecular marker there to its all cases, all comers. So I don't know. I mean, this study is now for PIK3CA, that the biological rationale behind it. But what if we use for all comers, even if we don't test for PIK3CA?
Yeah, so my reasoning is that in the era where we are going towards personalized medicine, if we have a cheap drug for personalized medicine, why not? And that rationale is there. So to me, I think this is what I thought of it. My only question was, why not use 75? And I think we'll have to wait for the full manuscript as to why it's 160. Even 75 might work, but I would, and the bigger thing was in India, our CRC population is younger. It is not the 7 decade. So there, probably your bleeding risks might be even lower than what is shown in this. So we probably on safer ground is what I thought. But I thought this was a very nice study, personally, to use. Right. Going to the
Even
next. Yeah,
sorry.
yeah, please go ahead. Please go ahead.
You highlighted that this study had particularly early stage patient. Even then, it had shown a benefit that even
Yes.
treat were low. Our population are a higher stage patient, so the
Yes.
benefit may be more in them.
Yeah,
Okay.
and that goes to Akhil's point in that PIK3CA is common in our population. So
Yes.
probably, it makes sense. Yeah, yeah. Going to the next one, this is the breakwater study. This is the first line trial. BRAF mutations we know they're particularly aggressive. 1% to 12% of all metastatic patients have this. Encorafenib plus cetuximab in the Beacon study was in pre-treated patients. In first line, we largely use doublet and chemo, doublet and Bev, and if fit, triplet plus Bev. So this was a much needed study in a rather niche population where they looked at encorafenib, cetuximab, and chemo, which is Folfox, and any chemo basically as standard of care. They allowed FOLFIRINOX, Folfox, FOLFIRI, and Capox, if I'm not wrong. And a fairly large study for such a niche population, more than 600 patients. And like a lot of trials nowadays, they use an hierarchical design in that one of their primary endpoints was overall response rate. And in the interim analysis, they would only test for survival if ORR was reached. Whether ORR is a good enough endpoint is a different question. But for the purpose of this study, they used ORR. And they found that the ORR was better with encorafenib plus cetuximab plus chemo versus chemo alone. It was around 60% versus 40%. And I mean, that was the major thrust of these results. And almost 70% of patients had a duration of response more than 6 months. We know that is tough in BRAF mutant, so that is something reasonably good. And if you look at the interim overall survival, which was tested because ORR was reached, there's around a 10 to 12% difference at 12 months. And the standard of care, the overall survival was 14 months. This is kind of the figure we expect in BRAF mutants. So the standard has performed as per what we expect, and this is definitely a better, the overall survival was better. The thing is that maybe this is not very well tolerated. You required interruptions in Cetux and encorafenib in greater than 50% of patients. Those reductions were required for encorafenib for 22% of patients, and around 10 to 15% of patients had to discontinue one of these two drugs because of side effects. So coming back to my questions, I'll start with Dr. Smitha this time. So these are my questions, and please feel free to raise any other points that you want. Is this data good enough for you to start considering this in patients with BRAF mutant cancers?
Yes, I'm sorry. Okay, the video is started.
Yeah.
So, I mean, this data looks promising in the first line setting, as we had seen that it can be used in the subsequent lines from the previous studies. You have put a rider, no cost, no logistic constraints, which is a challenge for us. But okay, considering no cost constraint is okay. But cetuximab is a difficult drug to deliver. We have limited experience. There are a lot of side effects, dose modification. And Encorafenib, I don't have any experience with a BRAF inhibitor, unfortunately. So difficult to say about the toxicity in real world.
It is it is
Yes.
reasonably toxic.
Yes.
I've given it to just 4 patients, I think, and all of them had to spend a bomb to get it. And I think 3 of them had to come down on dose because of diarrhea. So that's my limited experience. And I agree with you that even if it becomes standard of care, I don't think many patients will be able to afford it. Akhil, your thoughts on whether all patients in the comparator should have got FOLFIRINOX plus BEV? This is a registration trial. They are going to take the fittest of patients. Do you think they could have done that?
Yes, sir. So this the experimental arm was also very toxic. So as we know, encorafenib and cetuximab both are a toxic combination. Uh, so if the patient is being offered in an experimental arm, this toxic combination, it is also fine to utilize FOLFIRINOX plus BEV in the opposite arm. In fact, what we presently do is FOLFIRINOX plus BEV in BRAF fit patients. So that is our standard of care presently, considering all the cost and logistic constraints. So definitely, FOLFIRINOX plus BEV would have been a better arm if it would have been taken, and but that is what we always know. The trials are designed in such a way that the differences can be somewhat escalated as much as possible.
Fair enough. And last question to you. In BRAF mutants, do you consider, assuming the patient is not on a trial, first line, second line, do you ever use anti-EGFR directed therapy in BRAF mutants?
Not without any BRAF directed treatment. It doesn't make sense, and we don't have any evidence for that as well. And some trials of amivantamab are going to come shortly, or
Yeah.
AMI studies, but that are also not for BRAF mutants. But that will, when subcutaneous amivantamab becomes available, it might replace cetuximab in affording patients. That is one of my thought, but
Okay.
I'm not sure about it. We need
Oh,
to see further.
yeah, I think they will add it to Citax is what I feel, but fair point. Bhavna, madam, your thoughts? I mean,
I
do you feel
completely
that
agree. Mhm.
in BRAF mutants, if you have the option, will you think of this as a first line with this data?
So I think this is a pretty tough treatment to handle. And my standard of care in BRAF mutant is FOLFOXIRI plus bevacizumab, and which is fairly well tolerated. It's cost effective. We have a generic option available, but yes, the survival curves look very impressive. There is a plateau, and at 6 months and 12 months, and if you hear Scott Kopetz talking about it, you want to use it from Monday morning in your clinic. And there is a separation, and there is the survival is almost double if you see the median 6-month and the 12-month survival. So these, I mean, one can't ignore these survival curves. So I think with using these drugs more, I'm not so much worried about the cetuximab toxicity as the encorafenib toxicity. And when you combine the two, and the drug rash can be pretty bad. I've used it in a few patients. So, and the diarrhea as well,
Yeah.
as you said.
Yeah, the diarrhea is terrible to manage.
And the biggest criticism I have, as Dr. Akhil said, in BRAF mutant, they have not used the standard of care today.
They've allowed it, ma'am. They've allowed
They've allowed
FOLFIRINOX
it.
plus BEP. Yeah. So
Okay.
it's FOLFOX, FOLFIRI, Capox, and FOLFIRINOX.
How
We
many
don't have
had
the.
FOLFIRINOX? Just
It's not there in the
okay.
presentation, so I don't have those numbers.
Okay.
But the only thing is that so they allowed these comparators because not all our patients can get folfirinox plus Bev, and that's
Yes.
probably the converse point. So yeah, I mean, I think this trial will come positive. It will be one of the standards of care, but I think we need to see how many patients we can use it in. And I think 30 to 40% of our patients will need dose reductions. That's what I feel, but let's see.
And the other drug which I've used in some of my colon cancers, not first line, but third, fourth line in BRAF mutant, is dabrafenib and trametinib.
Dabrafenib, yeah.
Yeah,
So,
and have had some fantastic results with
okay.
that. Yeah.
So, what are your thoughts on the FDA not allowing it in colorectal cancers? They have explicitly said that dabrafenib don't use it in BRAF mutant colorectal cancers.
So we've used it like when we've run out, we run out of
Yeah,
options
yeah,
pretty
sure,
quickly.
sure.
And we've used it when we had no other option, and the patient had this typical BRAF V600E mutation.
Yeah, yeah.
And one patient is still being treated by my friend Toby in London, and is still on. I mean, we keep messaging each other that this patient is still on dabrafenib, trametinib. So we've had some long responders with that, and again, I think I would not recommend using it routinely.
Yeah.
So,
But I agree with you. I've given it to a couple of patients explicitly. I normally don't do it, but I've shown it to them that it's not approved. And I was not very convinced on why they didn't allow it. They have just mentioned that intrinsically BRAF V600E is resistant to this combination, but I don't know the mechanism behind it. So even I've used it in a couple of patients. So these are my thoughts on it. That I don't use anti-EGFR and BRAF. Yeah, okay, go ahead.
Sir, I wanted to make a point because I treat thoracic oncology also. So in BRAF V600E, we see quite heterogeneous responses even in lung. So what happens? Some patients of lung responding very well to dabrafenib and trametinib combination, while some patient not responding at all, progressing within 2.5 months. So I think here also, since we have experience of small number of patients, we might not be able to reach an answer. But yes, seems dabrafenib plus trametinib is not so effective BRAF inhibitors, at least for lung and colorectal. It is doing well in thyroid cancer. That has been our
Yes,
experience.
I was just going to say that.
Yes.
But yeah, I mean, when we run out of options, what do? These are
Yeah,
tough tumors
definitely,
to treat.
definitely.
yeah.
Completely
BRAF
agree.
mutant.
And
Pure.
PS1 patients, I mean,
Yeah,
young
yeah,
PS1, and
totally,
yeah.
totally. The third trial is the doublet immuno. This is the Checkmate 8HW. This is the first readout of this study. There's still further results that will come later. So the baseline for immuno, we are aware of the Pembro trial, Pembro versus standard of care in more than 300 patients, and that doubled PFS and it established Pembro as standard of care. There were some issues with the Pembro data. 25 to 30% progressed very quickly, and there is some doubt as to whether all of them were MSIH truly, and whether these were the ones that progressed early. And initially, because of crossover, they said there was no OS benefits, but the final 5-year data actually says that OS is also better with Pembro, despite allowing crossover in close to 60% of patients. Coming to the Checkmate trial itself, the Checkmate HW itself, you had 3 arms: Nivo alone, Nivo EP, and investigator choice. I think in the current era, we wouldn't want an chemo alone arm, but this was the design of the trial. Uh, Good things about the study to me was that 84% had a centrally confirmed MSI high status. They included almost 40% of patients who had already received one line of therapy, which is quite a brave call in a registration trial. 14% had Lynch syndrome, and PDL1 had almost no correlation with MSI high status, and I'm happy they said that aloud in the paper, in the abstract. Now, the progression-free survival clearly is better with the combination. It's 70 versus 50 at 3 years. The study actually has a good long-term follow-up. The 3-month, the PFS rate was 68% in the combination and 50% in the Nivo alone arm. Other characteristics that ORR also improve, and as expected, when you use EP, there are increased IRAEs, and this was all grades as well as grade 3 and 4. The good thing is that even the Nivo alone arm tracked well in terms of health-related quality of life. So those were the major highlights of this study. So these are my questions, and maybe this time I'll start with Bhavna ma'am. So you have Pembro, which had if PFS is a decent endpoint in immune checkpoint inhibitors, with Pembro it was around 40%. Here both Nivo and Nivo EP are better. Nivo is around 50%, and the combo is around 70%. So how does it compare to that? And is this data enough for you to say this is one of the standards of care at least, and is it practicing?
So I think the data is very impressive. The only thing is the survival data with, I would love to see down the line with Nivo alone, because we know that with dual checkpoint inhibitor, it's obviously adds to the cost. And the 3-year survival is only 10% better, 60% versus 70%. So it'll be very good to see what the overall survival down the line is, because again, with the head and neck data with low dose nivolumab, I think this is something which we should be looking at down the line. This is very exciting, very practice changing. The progression-free survival has still not been reached. I think the median follow-up is 2 years.
I think it's more than 2 years, ma'am. They had a good follow-up for
Yeah. So no, I am convinced, but my point is that whether we can get away with just a single agent immune checkpoint inhibitor, and maybe with a longer follow-up, we'll be able to know that. With the dostarlimab study in rectal cancer, 100% overall.
Yeah.
And every meeting, every other meeting, we ask Len and sometimes Andrea, if she's there, that, whether, and it still holds true. So whether all these checkpoint inhibitors are similar, we don't know that. And so dual, of course, toxicity and cost, mainly financial toxicity. So I think the data is exciting for checkpoint inhibitors in MSI high, and I'm all for low dose checkpoint inhibitors, which we are using in so many of our patients here in Raipur as well. And
what do you do for patients who progress on immune checkpoint inhibitors? Who have definite progression? I mean, you are clear that this is progression. What do you do?
So, all the clinical trials in first-line metastatic colorectal cancer, they've been done with chemotherapy. I would go with the RAS and BRAF status. And based on that, we would go with first-line chemo plus Bev or whatever, or cetuximab. So I would just move on to the standard, because we know that, none of these patients were tested for MSI in those times, and these drugs they have not shown that, if you have MSI high or stable, MSI high is like 5% of our population. None of these trials have shown that, these patients in advanced colorectal cancer, the MSI actually has poorer outcomes. Yes, we know that patients who are MSI high are not very chemo responsive, not very radio responsive. But in metastatic setting, I think I'd go on to the
shift to standard chemo as you would.
Yeah.
Fair enough. So interestingly, in the Pembro trial, what they did was most patients on progression got chemo plus immuno for whatever it's worth.
So I wouldn't do that.
Yeah.
Because
I find it odd as well. Yeah.
And I wouldn't
Dr. Smith,
recheck, MSI status, because it doesn't change throughout a patient's.
Yes, that's a very good point. I've seen that being checked, and that's a good point. Dr. Smita, your thoughts? I mean, Pembro has now been there with us for a while. Is this data convincing enough for you to use, assuming there are no cost constraints? And I think one thing they got good is they used a 1 milligram per kg EP, which kind of helps us. So would you consider using this?
Yes, because the EP is for 4 cycles only, and then you follow it only with the nivolumab maintenance.
Yeah.
And from other studies of Nivo EP combination in other malignancies, we know it makes a deeper response, and that deeper response may give you a longer survival PFS. So I'm not sure in this data if it is there that the patients who responded actually, this is the median PFS for the overall cohort. For the responders on Nivo EP, was the survival even better?
Oh, okay.
So
I think for responders, I don't know whether it was part of what was presented. I can check. The responses were better with the combo as expected.
yes.
But in responders, what happened, I'm not sure. So
we-
do you use low dose immuno in your patients in MSI high
we
cancers?
use low dose immuno in many indications, as Madam was also saying that that's one of the cost effectiveness of the immunotherapies in our practice. So including colorectal, other malignancies, low dose immuno is there.
Yeah, I think
But
the
the
head and
patient
neck
population
trial,
is very small for
yeah,
colorectal.
sure. Like all solid tumors, I think 3 to 5% is where we play around with. Akhil, is there any time when you're not sure of an MMR report and you recheck it? And why do you not? And I'll come to where I'm coming from after you answer.
Yeah. So, sir, I would like to would give two comments. One comment
Sure.
is that MSI high in rectal cancer might be slightly different from MSI high in colon cancer in terms of responses. That is first point. Because we have seen dramatic responses in rectal cancers, but it is not that high in colon cancer, in my experience till now. There might be some rationale for that. I'm not very sure for that. Dostarlimab trial is only for rectal cancer, very high responses, and we have a cloud study, and we are going to add some other arms to it as well for locally advanced rectal cancer as
Sure.
well. So coming to the actual question which you asked me, when we are not sure of MMR status. So there are some times when we have done MMR by HC and we find that only one of the protein is not being expressed properly. In that case, we try to get it confirmed by other methods, either NGS or other methodologies. But otherwise, in 80 to 85% time, MMR-IC is sufficient enough and gives very concordant results. That has been my experience.
Sure, I agree with you. The other thing on the rectal versus colon cancer, and this is, I think, still being debated about, is that more of the studies with colon cancer have been done in advanced cancers. More of the studies with rectal cancers have been done in early cancers. And there is that differential response. For example, if you look at the niche study, they had 80% PAT-CR as well. It was not 100%, but it was 80%. So I think it's also stage dependent in terms of immune checkpoint response could be. And this is something, the MMR thing, I've now made it a rule that if there's only PMS2 loss, I always check because that's often a false positive. MLH1 can be lost singly. Usually it goes with PMS2, but it can be lost singly. But the moment I see a PMS2 loss only, I do recheck so that, I'm, because it's an important therapeutic call and I do recheck it. Great. So this is what I thought of it. Low dose, I'm pretty gung ho on it. A lot of my patients get low dose immuno. Right. This is the only ctDNA trial that I've been given. I think all the others will follow with Dr. Senthil. So this is the Altair study, which is a cohort of patients from the Circulate Japan study in patients with stage 1 to 4 colorectal cancers who've been operated and given standard therapy. Those who were ctDNA positive were randomized to 6 months of TAS 102 versus just placebo. And this was a study of 240 patients. They had a very intensive ctDNA and CT monitoring. It was done every 2 months. I doubt we will do that in practice. So important things were 27% of patients had oligometastatic disease, and they had a rather loose definition for enrollment of patients. It could be during the MRD window, which was 2 to 10 months, 2 to 10 weeks post-surgery, during adjuvant and during surveillance, and approximately 50% of patients remain ctDNA positive after 1 month. So the intent to treat, the per protocol data for all comers was negative for DFS in that there was no statistical difference in terms of PFS for whether you give TAS or not. And the difference in survival was around 3 months numerically, but this was not significant. But in patients who had stage 4 oligometastatic like disease, there was a difference in survival, and this was 9 months versus 4 months. And this was statistically significant. So I'll start with Dr. Smita. What are your thoughts on using ctDNA first in stage 2 and stage 3 resected cancers? This included stage 4 as well, but do you think of using ctDNA in stage 2 and stage 3? And do you believe it is prognostic when positive? Dr. Smitha, you're muted. Sorry.
Yes, so it is definitely prognostic. The timeline of that is yet to be defined. What is the best timeline after surgery? Not for treatment decision making at this point of time for the resected colorectal cancers. We don't know what is the actual timeline. And given
Okay.
coming to this trial, the inclusion-exclusion criteria are a bit difficult to understand, and the time points of inclusion post-surgery, the oligometastatic disease. So the data is not very clear on which patients would actually benefit, and only the oligometastatic has shown some
Okay.
benefit in
So
this.
you feel ctDNA is prognostic, but you wouldn't use this study for giving TAS for 6 months. That is the
No,
sense.
no.
Fair enough. Dr. Bhavna?
So I completely agree. I don't think there is any, TAS has no data in adjuvant setting, first of all. I don't know where they've decided to use TAS 102.
I think it was convenience. They wanted
Yeah.
something oral and they just said, okay, let's do this.
Yeah,
That's what I
and
think.
I don't use ctDNA at all. And it is prognostic, we know that, but we don't know what to do about it. What do you do if you keep giving chemotherapy for stage 2 and then, it still remains? Do you continue? What do you do? So none of us have an answer to this, actually. So
Is there any place do you find it helpful in decision making? We know it's prognostic, largely all of us will agree.
yes.
But do you use it therapeutically?
So
Anyway.
only in where I can't get tissue, and like in bone, we need to do, that's the only place where finances are not an issue and we can't get tissue. Then I would send for ctDNA. Or we had just had a patient who refused a biopsy.
Okay.
I mean, so she refused it, and thankfully we were able to diagnose her on the ctDNA. I know it's not standard. So these are the only situations I would use, yeah.
Akhil, your thoughts? I mean, beyond prognostic value, anywhere you use ctDNA for decision making?
Not so, sir, in the present practice and based on available data. We know that it is prognostic, but it does not change our decision of adjuvant treatment or not giving adjuvant till now.
Okay, so you're comfortable with clinicopathological variables and you stick to that. And in stage 3, I think for sure. So I actually do use it in stage 2 cancers where I'm not sure I want to give, and then this value gives me a nudge in some direction. And I agree with Dr. Bhavna's point that where did TAS come from and why 6 months? If at all the peak recurrences are 18 to 30 months, give it for longer and maybe you'll have got something. But I think this is hardly practice changing, but it just adds to data on ctDNA is what I think. Coming to the last study, which is probably the weakest study of the lot. It was just called deeper, but it's not deep enough. This was, the cetuximab to triplet chemo in left-sided, in all cancers with a, stress on left-sided. We know that the triplet study with panitumumab is already negative. So what they did was they looked at depth of response in FOLFIRINOX plus cetuximab versus FOLFIRINOX plus BEV. And they said that the study would be positive if you had a depth of response which was 12.5% more. That's a really iffy endpoint, according to me, but it is as it is. And they had a fair number of right-sided cancers and at least 8% BRAF mutant. And if they had been smarter, I think they would have excluded that population. But that's how it was. And the 2021 publication said that, responses were better, but there were no differences in PFS OS. When you made it RAS and BRAF wild type, maybe some difference. When you said RAS, RAF, and left-sided tumors, maybe some difference, but all of them were not statistically significant. So this was the PFS results and the OS results. The PFS results for left and right-sided cancers. There were differences, left-sided cancers, not so much in right. OS, again, similar, differences, hardly any difference. But probably the only place where it makes sense to use this combo, I wouldn't recommend it, but if at all you had to, was in RAS, RAF, and left-sided, cancers. You see an overall survival difference of around 10 months, which is impressive, but the numbers are only 180 patients, so maybe a pinch of salt. So I'll start with Dr. Bhavna. Is depth of response any kind of endpoint in such a study? And would you use this combination anywhere?
So no, I disagree with even overall response rate. I disagree with PAT-CR as well. I actually thought that FDA had lowered their standards when they started using PAT-CR endpoints. I spoke about it. So this is not right, I think. We should, in this setting, have overall survival as an endpoint.
Or at least PFS, right?
Or at least,
at least, yeah.
Yeah, I mean, this is just, trying to just
find an indication for a drug.
Yeah, and
you can say it.
I shouldn't use those words. So anyway, so basically I would not use, in colon cancer, we have 5-FU oxaliplatin and we have irinotecan. So for me, sequential treatment is more important than concomitant treatment because, I'm able to handhold the patients for longer. The only place I would use something where I use everything along with a targeted drug is neoadjuvant setting, where, we are aiming to cure the patient. But otherwise, I wouldn't use it.
Okay. So, Akhil, I mean, I think all of us would agree on the endpoints being plus minus. Do the 50-month survival data surprise you? I mean, colon cancer is doing well compared to 20 years back. But if you have a cohort of patients surviving for beyond 4 years, I mean, what is that telling us?
So definitely, sir, it's somewhat surprising to get a median survival of more than 4 years in this population. Usual median survivals are in the range of between 2 to 3 years to be on average.
Yeah, and we have collated data from 10 institutions. It will come out in some time. The survivals in India are 20 months. So we have a long way to go from 50. So Dr. Smitha, is this practice reaffirming in that don't use this combination? Does that help you, definitely say that don't use this combination?
No, I mean, there may be a set of patients who may benefit this RAS wild type, BRAF wild type, left-sided, fit young patients where we can use, and you have the other therapies for the second line then. And the survival, though we are discussing, it's impressive, median survival of 4 years, maybe for some select few patients, not for all.
Yeah,
Also, this needs to be a post-hoc analysis of the trial. And
yes, this is just secondary endpoints. Fair point. So I actually think exactly what all of you said. I would think that maybe use it in those who are also HER2 negative and PIK3CA negative, but this is looking for indications. This is just thoughts I'm saying out aloud. And I don't use this combination at all. I think, as Dr. Bhavna said, this is one of the areas where sequencing is better when you have a larger negative trial. Triplet was negative, and this is also not showing any significant differences. So I think we are on the dot. I'd like to thank all my panelists for their inputs. Thank you so much for your time.
Thank you, Dr. Anant.
Thank you.
Yeah, thank you, Dr. Anant. And as usual, it was a wonderful session and with a good discussion on all the topics. The next one will be by Dr. Sendil. And the panelists for this session are Dr. Amol Akhade, Dr. Viraj Lavingya, and Dr. Anant. I have to ask you to stay back for this. All the panelists need no introduction. Dr. Sendil, a bit of pressure on you. 2 of your panelists out of 3 said they will do a panel only if you moderate. So, no pressures. Please go ahead.
I can't believe this is usually the other way around.
No, it is absolutely true. I am not telling it.
I was one of them.
Yes.
I was one of them. So I thought it's a great time to actually learn something from Dr. Senthil.
Today,
Otherwise,
today, for once, not for once, I think I will certainly be at the receiving end today because I have rarely done anything that I'm going to talk about today. So it's open free for all. Lovely. Okay, lovely panel, Anant. Learned a lot. Let's hope that we will get a little more enlightened with what we will talk about in the next 40 minutes or so. So I have 3 studies on circulating tumor DNA, not necessarily path-breaking studies that we will start using from Monday morning. But we need to be ready to be using it sometime. So this is the process of getting ready, getting dressed up to go to work, not really ready to use them in practice. And then I will quickly review a couple of abstracts on in neuroendocrine tumors. I will do something very similar to what Anant did. I will quickly run through the abstract and then ask some questions. And then at the end of each abstract, let me summarize what I think the carry home or take home from these abstracts is. So the first abstract is circulating tumor DNA for detection of molecular residual disease in patients with stage 2 and 3 colorectal cancer. Final analysis of the bespoke CRC subcohort. So this is prospective. It's an observational study. So there's nothing like a randomization between patients who are positive, negative, and then decided to do whatever it should be. But this is a prospective observational study, 133 US sites, looking at the ability of the Signatera test, which is a tumor-informed test, to look at adjuvant. ACT stands for adjuvant treatment decisions. It took a couple of hours for me to figure out what ACT was. So it is to look at ACT decisions. So there was a sample as shown on your slide drawn before the surgery, and then there was a window 2 to 6, week 6, 12, 20, and then as you see on your screen, a sequence of ctDNA samples were drawn and analyzed. Remember, this is an observational study. Both stage 2 and stage 3 patients were included. So this is the impact of Signatera on adjuvant treatment decisions. So impact of decision making was there in 16%, that is 1 in 6 patients. So let me start by asking Anant, is a 16% change good enough to recommend Signatera to all stage 2 and 3 patients as of today? I didn't find the data that's in the bracket there, but it was in the ASCO news that was, circulated by, of course, the ASCO guys. And Dr. Kim had said that 35% escalated and 59% de-escalated. I didn't find anything to substantiate this data in the slides that were provided. So I think we'll ignore that for the time being. 16% change, is it good enough to start doing this test, Anant?
I don't think so. I think we need to use it selectively, and I would currently use it, if at all, only in stage 2. And I don't routinely use it.
Okay. Amol, do you do Hodgkin's disease? Do you do PET CT scan? You do. Say yes, Amol.
Yes.
You do a PET CT.
I know where it is going. I know where it is going.
So no, I'm not going to convince you about anything, Amol. That's not my job. I'm just going to put some points ahead. So do you do a PET CT in patients with localized esophageal squamous cell carcinoma before you do cross protocol or neoadjuvant chemotherapy followed by surgery? So the point I was trying to make, Amol, I know you know where I'm getting to, that when we first started doing these, the percentage change that was expected, or rather that was there, was the same 15%. So 1 in 6 patients were the ones who benefited, and we comfortably adopted it. But we have some hesitation here, various reasons starting from cost, robustness of the test, the clinical evidence that is available at this point in time. But Amol, when you compare it with those numbers, do you think it's worthwhile thinking about it, not necessarily doing it versus not?
Yeah, definitely. That is something we can think about, and we can have an informed decision with the patient. But generally, I will not yet fully convinced with the utilization of it.
Okay, so we are starting to think that it may be worthwhile because it's making a change in a percentage of patients, which I think is clinically significant, though sounds very modest. This is how we change practice in many other malignancies. So I'm sure we will do it at some point in time. For me, what was very interesting is that only 7.54% of patients with stage 2 were positive MRD, and only a third of stage 3 were positive MRD. Now, whether we should adopt this to decide, we'll come to that in a moment. Viraj, do you routinely use this in practice, stage 2, stage 3, or both?
So with the profile that I work currently, I cannot do it, but
Okay.
Using your example, if tomorrow this is a 5,000 rupee test, to me, it's a no-brainer. It should be offered to all stage 2, stage 3. And I'll tell you why.
Okay.
Like the example you gave, whenever the new modality comes in oncology, it typically, and the ballpark figure is 10 to 15%, treatment decisions were changed. And you gave a great example of PET scan. Importantly, and these numbers actually are from the subdivision of the pie charts. So in the original presentation at ASCO GI, this 16% were then further showed as that what were these 16%, and these numbers that you showed, that about half de-escalated and about a third escalated. While the important thing is in the 84% where they said it didn't change our treatment, but then they also had a questionnaire. Did this test give you a confidence?
Yeah.
And in that 80+% said yes.
So did it reinforce your decision to do or not to do was the question.
That is the full picture.
Yes. So it's like doing can assist, I suppose.
Should we
I
say
think it's like doing can assist, I
to...
suppose. You want to have something a little more objective to substantiate your decision, not necessarily that you will change your decision.
That's right.
It makes you feel a little more confident, I suppose. But it's too expensive to to just gain some confidence. Amol, go ahead.
So if you decide, so I wanted to ask everybody that if you want to do it, do you do it from Signatera? Because the study is 16% is from Signatera study.
Yeah. This is from Signatera. We'll come to that broader question in a moment, Amol, whether the Guardant one is better or the Signatera, because these are the two tests at this point in time which have the maximum data. So I'll come to a more important point, which I think is also very relevant. So I want you to not run through the data on this slide. Let me take you through this. Let's start with the bottom of this slide. This is the disease-free survival based on MRD results at baseline. Now, on the left is stage 2 patients, on the right is stage 3 patients. If you're MRD negative and stage 2, your 2-year disease-free survival is 92%. If you're MRD and stage 3, you're 87.5%, almost very similar. My question is that 13% or nearly 14% of patients relapse with stage 3, even if their MRD is negative. So are we happy not to do any treatment for these patients who are MRD negative, considering the fact that if you, let's say, take breast cancer, 10% is the cutoff, 12% maximum cutoff to say, I want to treat this patient with some chemotherapy or escalated therapy. So here you have a 13%, 13% chance of getting the disease back, which by breast cancer standards is a high risk of relapse. Anant, are you happy to leave these patients alone with the data that you're seeing on the screen? Or you would say, I want to do some chemo. I may not do hammer and tongs 6 months of chemo, but some chemo in patients who have MRD negative also. Let's leave alone the N1, T4s, the high risk, low risk. We'll come to that in a moment. But do you think you're happy with this 87.4% and leaving them alone?
So the thing is, if you take stage 3 cancers ballpark, and you give them standard surgery and chemo, around 45 to 50% of them are going to recur, right? It's anywhere between 40 to 60.
40% right? Around that, at least.
Yeah. So almost all of them would benefit in terms of DFS and OS with some kind of chemo.
Right.
And that is where my answer comes from.
Yes.
That irrespective of in stage 3, it is going to be very tough for me to convince myself or the patient that I'm going to not give you chemo despite there being a 10 to 15% chance that it will come back. So I'm not convinced on using it in stage 3 yet.
Okay, lovely. So, so you still think that this number is not good enough for you to totally give up chemotherapy in patients with stage 3 cancer. Amol, do you agree with Anant that this number is not good enough? We would still treat our patients. How much to treat is a totally different question. It's an open question at this point in time, but do you agree with Anant?
Yeah, I agree with Anand, especially when we do not have a prospective predictive trial in which
Yes.
we have proper randomization of with chemo, without chemo in those who are MRD negative versus positive. So we do not have predictive data. These are prognostic data. So I will not, for stage 3, definitely, I will err on giving a therapy rather than
Some
not
treatment
giving.
rather than not doing anything. So Viraj, having, you said you do, fine to do. How do you handle this MRD negativity and treat versus not treat in patients with stage 3 disease?
So correct. So the answer is twofold.
Yes.
Because of the guidelines and the medico-legal pressures that we
I think that's okay. We will not get into that intricacy, Viraj. From a scientific standpoint, no, I know that the guidelines still not recommend. So I said, you're putting on your dress to go out to work. You've not yet gone out to work. So when you're putting on your dress, you should be prepared for the day's work, right? So I'm talking about it from that standpoint. So will you be comfortable at this point in time to say, okay, I'm fine not to do it? Or would you say, if it's a frailer, older patient, who is a little bit shaky, not very keen on taking treatment, would you start then dissecting out that patient population and then saying, in this patient, I would certainly not treat. In this patient, I think I'm okay to not treat. Would you have some, in the clinic? Amol is not agreeing with me, but, would you think about a situation like that? An N2 stage 3 versus an N1 stage 3.
Correct. So I have put patients on observation in my practice. Why I was telling you a detailed answer is because, please hear me out for 30 seconds.
Yeah.
Scientifically, I have no doubt in my mind that this 14% is inevitable. Whether you give K-pox, FOLFOX, FOLFIRI, doesn't matter. And hence, even though we are afraid that we are not ready to accept this 13% relapse rate, that's the fact, because the next slide you will show that whether you give chemo or not, in MRD negative, the curves are on top of each other. Having said that, because of the current guidelines, I do tend to offer these patients, end up offering these patients at least capecitabine monotherapy. But scientifically, I'm convinced that these patients do not benefit by giving chemotherapy. And this 10 to 14% number is by far the common number, whether you see the Guardant data, whether you see the Signatera data. And this is because of the lack of technology. Current technology does not pick up the peritoneal and lung metastases well. And that's the Achilles heel with the current technology. Maybe a few years later, we will find a stronger MRD, which will even pick them. And then this number will start shrinking further.
I know, I agree. Hopefully what you're saying will happen. But for me, I need more data granularity in this group of patients. Yeah, Amol, I'll let you talk. In this group of patients to know which are these patients who actually recur, which are these patients who don't recur. For me, I think the N1s with MRD negativity probably have a lesser chance of recurring compared to a N2 with an MRD negativity. A T4 is different from a T3. So just like pathologically, we divide them into those high risk, low risk to treat for 3 months versus 6 months. I think some substratification of this MRD negativity in stage 3 will come, and then maybe we will be able to use it in practice better. Amol, go ahead. Amol, go ahead.
The point that was raised by, I think, Vamshi in the chat box is that for those who are not fit for chemo, elderly patients, cardiac risk factors, and in which MRD is negative, there we will probably use this data. My counter question is that, did the trial have this kind of patients themselves? I don't think so. The trial had this kind of patients.
But this was observational, Amol, so we just don't know. It was an observational study.
No, in that observational study also, there was no such subset of patients who were not fit. So we cannot extrapolate saying that we will use this data for those who are not fit for chemo. No, we cannot.
Agreed. So I'm just saying that, you're finding some reason to convince your patient or not convince your patient. I'm talking from that standpoint. I'm not saying that there is scientifically robust data to use it. I'm saying that, you sway this way or that way, depending upon what you see, right? So that's the point I'm trying to make. Because look at it, if you're positive, look at your 2-year disease-free survival. It's dismal. It's 45% for stage 2 and 35% for stage 3. So that's really terrible, and you don't want to leave somebody without any treatment. Anand, you wanted to make a point.
Yes, sir. So, I mean, I think the frail patients, which was mentioned by Vamshi, that's an easy out.
Yeah.
I mean,
I think you're
you're
not
going to take a
audible.
negative.
Yes. So I think it'll just
I
push
am
you
not.
this way or that way.
Am I
So
audible
yes, Anand, go ahead.
now?
Yes, you're fine. Go ahead.
Yeah, that's so that is an easy out. In those patients, you're just going to, this is a confidence building measure. The key thing is, are you convinced on leaving those 10 to 12% that Virat said? And I think that will be a heads or tail answer if you put 10 people on the line to answer that question.
Yeah, that's right. That's why I said you need more data. The other thing is, when you treat these patients who had MRD positivity with chemo, you see that on the whole, 75% tend to clear their MRD, okay, or get to MRD, should I say. But what is more important is what's there in your screen to see that even if they clear their ctDNA, their prognosis is still poor. You see those curves. The red curve is patients who did not take chemo. The patients who did not clear. The blue is patients who cleared. Even if you cleared, your outcome still continues to be poor. It's better than if you don't clear, but I don't think it is still so very good. So for me, I think we need to have a totally different trick to treat these patients because they seem to be having really poor prognosis with the kind of treatments that we are having today. So we have a lot of work to do in front of us to be able to apply this and get our patients to better outcomes. So here is the one that Viraj was talking about. This is stage 3 and 4 put together. On the left is patients who are MRD positive. On the right is patients who are MRD negative. Now, this is stage 3, 4 put together, very heterogeneous group. The right side shows that if you gave chemotherapy for a negative patient, they didn't do any better compared to if they didn't take chemotherapy at all. The one on the left clearly shows that if you did chemotherapy to a positive patient, your outcome is better. So that's 2-year DFS of about 40 versus 24%. That's about 16% betterment. So I think at this point in time, we know that this is very strongly prognostic. This is trying to tell you that it is also predictive. I'm not very convinced based on what I'm seeing on my screen that it is strongly predictive. I would say it's weakly predictive. I am not willing to get carried away by the right side MRD negative patients not showing any difference at all because there are a lot of stage 2 patients in this. There are stage 3 patients and all the different stage 3 patients. So I want some more dissection of data for me to really say that it benefits versus not. And this is observational. I think this is the best that you can get away with. Get with in an observational study like this. So that's where I would leave this. Strongly prognostic in stage 2 patients. I think based on the dynamic study, we're all talking to our patients about the test that's expensive. But if you still want to do, you're happy to do it because the probability of doing chemo comes down by half. It's 14 versus 28%. I think that's worthwhile thinking about. At least there is some data. In stage 3, I'm not very convinced at this point in time that it can help you decide till we have some prospective. As all of us said, we will want to do something for our patients with stage 3, even if they're MRD negative, not convinced at this point in time. So I come back to what Anant was talking about in his panel. This is even better. It selected some more patients for the celecoxib, something very similar to aspirin. So if you did it in your ctDNA positive PIK3CA mutant group, there seems to be benefits. So Anand, your thoughts on ctDNA, PIK3CA, and then deciding whether you want to use aspirin or celecoxib. We are adding a few additional lakhs of rupees to what we want to do. The point is that I showed you data that even if you treated them with chemo, you're not doing so great. So we definitely need to add something more molecular, targeted, whatever you may want to call that as. But Anand, what are your thoughts?
Yeah, so I think the point you made was absolutely right in that we need to do something more, probably. So that is why you see strategies like maintenance, drugs like this. And if you have an option like this, celecoxib or aspirin, which are not expensive and are showing some benefits, I think that's the way forward. And this is not a small number. It's
That's
almost
right.
a 900 patient study. So, and if you're having a reason, the only problem is that celecoxib, a lot of us are not comfortable using it for the cardiac issues that it might happen. But I think this is a step in the right direction for these kind of high-risk patients.
Excellent. So something needs to be done. Viraj, you had messaged, or rather you had put it up in the chat box saying that you do it for all your patients with MRD positivity. Is that you routinely follow?
Yeah, so because we don't do MRD. I'm doing aspirin for I think it's the last 5 years for all patients.
Okay.
Adjuvant chemotherapy.
Amol, I just want to recollect what Dr. Smitha was talking about. It made a lot of sense. It's a very simple, easy, cheap intervention. Our patients are younger, as Anand said. The probability of having a major adverse event is not going to be a big number. So why not give it to everybody with stage 3 disease? Do you think it sounds, easier to do something better than what we're already doing? 40% are going to relapse, as Anand said. PIK3CA is not going to be easy to do for all. He showed data that even in not the PIK3CA, PIK3CR, P10, everybody seems to be having some benefit. Till the time comes where we'll do broad panel NGS for everybody who walks into your OPD, that's going to be difficult. So do you think everybody can take aspirin? I kind of start to think that it's not a bad idea. Not everybody will benefit, but you're not going to cause too much of harm. Is just what's running in my brain. What do you think, Amol?
I would just like to ask you, sir, how many subdural hematomas have you seen for patients who are started on aspirin by somebody else for a myeloproliferative neoplasm which doesn't require any treatment?
I don't see them.
I have seen.
So
I have seen few. So
okay.
I don't agree that aspirin is a harmless drug.
No,
and
any drug is harmful, Amol, from that standpoint. I was talking about not a 75-year-old, a 45-year-old.
So something I would like to see some more studies.
Okay.
Let it come to the guidelines. I'm not too keen to start it just based on one.
Agreed. Absolutely agreed. You're very scientifically robust from that standpoint, right? So I was just trying to be a little more, practical, if I may say so. So anyway, that's fine. If you're not going to use it, it's fine. But this is something that, in addition to what you would do routinely, you may want to add on if you had the wherewithal to do your ctDNA and then decide what you wanted to do, because the outcomes, even with chemo, don't seem to be so great for these patients. Yes, Amol.
Yeah, I just wanted to ask everybody, now that we're talking ctDNA, a practical question. If stage 2 CA colon comes to your clinic with a ctDNA done by someone else and it is positive, and it is a stage 2 CA colon, will you offer adjuvant chemo based upon the ctDNA done by someone else, or you would like to repeat it, or like to wait?
I want to know who is that someone else, Who is that someone else?
So someone else who is unfortunately your colleague who has done it.
And I thought you were talking about the lab, not the individual. I want to know the lab. I want to know the lab.
No, the lab is a different story, but someone has done it. Stage 2 CA colon come to you.
No, I think, Amol, not the individual, but I think the lab is more important. We just have data from Signature and Garden. Anything short of that, I will not be convinced to make any decisions on that. That's my take. Viraj is nodding, so I assume he agrees. Anand, are you also nodding?
Yes, I think we need to be very careful on this.
I would say that this is not a standard lab. This is not being tested robustly.
So you'll repeat it from a signature. You'll repeat it from signature.
If that patient really says that I want, and then the signature will ask for the block of the patient also. So it's going to take 6 weeks. So all these have to be taken into consideration. So it's not an easy decision.
Okay.
So this is another interesting thing as part of the bespoke study. So when they looked at MRD negative versus positive patients, the first thing is again the same 1 in 6, 15% MRD negative patients recur. So this is something that we've discussed. We not get into that now. Will it help you to, personalize your surveillance protocol for patients who are MRD positive versus negative? Because if patients were positive and they were closely followed up, a third of them ended up having disease which would be amenable to some metastasis directed therapy, which we know results in better outcomes. I'm not saying that this is prospective data and we have a cohort from this that has been shown to improve overall survival. That's not what I meant. Would this be also a strategy that we may be employing in the future, Anand? Suppose somebody is MRD negative, less than 10%, just come once every 6 months, say hello to me and go. If you are MRD positive, you got a higher risk. I want to keep chasing your disease because a third of you may actually be a candidate for some local therapy. So would you do that in the future? Not immediately now, future.
So there are 2 points that I'd like to answer this via. One, in patients with oligometastatic disease, the role of perioperative systemic therapy only improves DFS. OS, not so much from available data, right? So assuming I've given 2 to 3 months of treatment to a patient, resected, curatively intent, if I have the ctDNA in front of me,
We seem to have
and
lost you.
it's
Yeah,
negative,
go ahead. Yes.
positive, I will definitely insist. I'll definitely insist on a slightly more intensive follow-up. Because once I have the test, I would rather act on it than not act on it. Whether I'm going to give more treatment is a different question, but
Right.
I would keep that patient under closer. So yes, it would.
Right. So I think that's where science is also moving, that your surveillance protocol may also be personalized depending upon whether you're MRD positive or not. So this is what I would say as the conclusion for this abstract. 1 in 6 patients have a change in treatment. Looks modest, but that's how we have changed practice. That's what history says. MRD status seems to benefit the predictive value of the Signatera test as far as chemotherapy is concerned. I'm not convinced for all patients at this point in time. Adjuvant chemotherapy is able to reverse the poor prognosis only in part. You need better strategies to improve outcomes. Intensive surveillance in MRD positive may help metastasis-directed therapy with possible improvements in overall survival in around a third of patients. So that's how I would conclude this first abstract. You guys agree with me? Yes. Okay, fine. A more quick point before we move on. We've got a lot of ground to cover.
Regarding the intensive surveillance,
Yeah.
my whole point is that if you do that, the same intensive surveillance on the MRD negative also, you may end up finding some patients.
No, the probability of relapse
it is to do with the surveillance rather than with the MRD.
No, so the point, Amol, is that you're then saying that this patient has got a high risk, this patient has got an intermediate risk, this patient's got a low risk of disease coming back. So I don't want to see this patient every 3 months to do something. I want to see this patient more frequently. Some triaging can be done as to how you want to follow. That's what I'm saying. I'm not saying that everybody should have in order to pick it up. Viraj, quick point before.
Yeah, quick point. So this data set plus the dynamic data set conclusively prove that if you have a negative ctDNA, even though you relapse, it is almost never in the liver, versus if you have a MRD positivity, almost 60 to 70% relapses are in liver. Now this is what they meant, the authors, that guided surveillance, that we know when we see liver 3-monthly MRIs or 3-monthly CT, in an MRD positive, you pick those small nodules here and there and you ablate them or surgery them and kind of, again, make them normal. So it is helpful in MRD positive also.
So I think
just a quick point, sir. Sorry. I think, if I may.
Yeah, please, go ahead.
Yeah, I think that's stretching the point. 1/4 of patients have disease in the liver, in the lung and peritoneum without liver disease. We can't draw that conclusion that it can guide our surveillance strategies on liver versus non-liver.
That's right. I would say you can just chase them closely. You might get a chance to do some MDT. I would not say that these patients will definitely get liver or lung disease, which will definitely be amenable. So I think I agree with you, Anand, that you might get one. So
of course you do CTTAP, but add an MR also in between.
Okay. So I don't think we know the best way to do this surveillance, but what I'm saying is that in the future, it might actually be helpful in doing that also. So we are talking about the future. Okay, we leave that rectal cancer abstract. I think I have so many points why you shouldn't be doing that, so we will not get into that. We just have about 7 minutes to go. So this is the starter net study. This is patients with gastroenteropancreatic, so that's intestinal and pancreatic neuroendocrine tumors. Treatment naive patients, grade 1 and 2, a Ki-67 of 5 to 20, or if you have a Ki-67 of less than 5 with diffuse liver metastasis, they were eligible. Randomization was everolimus lanreotide versus everolimus alone. The primary endpoint was progression-free survival, and the trial was positive. The hazard ratio was 0.44. The overall response rate was 23% for the combination versus 8% for everolimus alone. So the conclusion of the author was that this is a potentially practice-changing study in this set of patients. So Viraj, you're on my screen. Are you happy with the control arm? Do you think this is practice-changing for patients with gastroenteropancreatic neuroendocrine tumor? We just talk about the non-pancreatic NETs. The next slide is on pancreas. So your points, your critical issues as far as this trial is concerned for the intestinal or stomach NET.
So we know small molecule TKIs and everolimus do not do well in a non-pancreatic GEP pancreatic non-pancreatic GEP tumors. So, and in that sense, I do not like the control arm. And still the disease, the group that was selected is still heterogeneous. It's not all high risk. There are few not so high risk. And if you see in not so high risk, let's say 5-6% and not diffuse bulky disease or less than 10%, the benefit was not there, right? Whether you add a length.
Correct.
So it's only the bad disease, and we knew already that a bad disease, which is not a G3, but still a bad disease, everolimus monotherapy would fall off. So in that way, this treatment does not tell me anything new apart from the literature what we have.
Excellent. So Amol, would you agree with Viraj that this trial is not really practice changing as the authors claim it to be for various reasons, some of which Viraj has pointed out?
Yeah, I agree. In fact, someone has very beautifully said this trial is practice changing only for those who still practice the control arm.
Nobody practices the control arm, so that's the problem. So let me, ask you a question, Amol. So if you come to the left side of your slide, this is the guideline or the algorithm for management of gastrointestinal NET, not pancreatic. So if you go down to the grade 2, which is anywhere between 3 and 20%, your patient should be eligible for PRRT, Ki-67 between 10 and 20, extensive or bulky disease. If they satisfy all the 3 criteria, then they go and have PRRT plus a somatostatin analog based on the NETTER-2 study. I sent you these slides. Amol, your mail bounced back. I did send you in the morning, but I don't know, your mailbox must be full, I suppose. It bounced back. akade.amol.
Which mail?
I think it's akade.amol@gmail. Is that the one? Anyway, never mind. That's not the panel discussion.
He's a man of many IDs. So.
No. You're sending me the email of the slides.
Yeah. Anyway, never mind. Okay, doesn't matter. So the point is that the ideal treatment for this set of patients is the NETTER-2 study, but a lot of our patients cannot afford PRRT. At least in our hospital, the PRRT is quite expensive. It's nearly 2.5 lakhs. So 4 into that is about 10 lakhs for PRRT. So if somebody is not able to get PRRT, would you use everolimus plus octreotide in our setting for a patient who's got larger volumes of disease and cannot get PRRT? Because the RADIANT study is there. It's in the right lower corner of your screen, which has shown better PFS in later lines. So for large volume disease, cannot get PRRT for some reason, do you think everolimus plus octreotide is a reasonable option in the first line for intestinal NET?
Yes, it is.
It is. So you're happy to use it if your patient is not eligible for whatever reason for PRRT. Is that okay?
Yes.
Do you agree with that? Anant, you would agree with that also?
So 2 things, as Dr. Amol said, I think it's a reasonable option in that exact subgroup of patients that you mentioned.
Yes.
That is true. But I have 2 other options.
Yes.
One is capecitabine temozolomide is a decent option.
That's in the pancreatic tumors. That would be in the pancreatic?
Mainly in the pancreatic with some retrospective data in other Japanese as well.
There you are. Yes.
Yeah. So
there you are. You get CAPTEM in that set of patients, 10 to 20%.
Yeah.
Correct.
So that. And 2, to report a trial in NETs without clear-cut dota uptake reporting
Exactly,
is
exactly.
unacceptable in the current era.
So which I have put up in the slide there, saying we just don't
Yeah,
know the
I
dota
saw
sets.
that. Yeah. Yeah, because most guys, even in the ENET, say that MIB index is highly heterogeneous. Grade
Correct.
plus MIB index is what decides your treatment.
Absolutely.
So this is iffy to say the best.
That's right. So for patients with pancreatic, you've got a list of options that are there here.
Yes.
Of course, everolimus is one of that, but that's not the go-to option for any one of us, because if you have large volumes of disease, you want response, and these TKIs give you response in single digits, 8%, as I'm showing you on your screen. So it's not a great treatment. So for me, as much as our panelists are saying, this is really not a practice-changing study. But for patients who, for some reason, are not candidates for CAPTEM, or not candidates for PRRT. I can't, think about a patient who's not a candidate for CAPTEM, but a candidate for everolimus, because it's a much more difficult combination much more difficult drug to handle everolimus than CAPTEM. So that maybe is a small population of patients in whom everolimus plus octreotide in our setting, we don't have lanreotide in our country, so would be an option. Cabozantinib, this is the last one. We've got 2 minutes to go. So looks like if you don't know what to do in any cancer, you can use cabozantinib. That's what it looks like. So Amol, is that what we will make as the concluding statement?
Yeah, it is poor man's TKI, or maybe any other oral drug that you want to replace with. Whenever nothing works, you do cabozantinib.
That's what it looks like. So this is called the cabinet study. So this again showed that there was a PFS benefit in these set of patients. So if you have exhausted all your options, your patient is still fit enough to receive cabozantinib. Now you'll have to have a patient like that. That's not an easy thing in patients with neuroendocrine tumor, especially towards the end. But if you have somebody, then for that patient, cabozantinib is an option. So we have touched 8:30. I will stop here. So for me, quickly to summarize, ctDNA is really promising, as you would diplomatically say when you are not convinced about its applicability in day-to-day practice. Stage 2, I think all of us seem to be on the same page. Since there is some prospective data, we are open to using it, but the lab is very important, not necessarily your colleague. So if you've done it from a standard lab which has got good data, then I think it's okay to employ. Stage 3, we are not ready to use it in daily practice, because in spite of having a negative MRD, still about 13% relapse, which is not acceptable in today's day and age. So in such patients, you may still want to do some treatment, maybe in a frail patient in whom you may not want, your mind is saying, don't do chemo, find out some reason not to do chemo, then you can do this. And then if you find MRD negative, you may avoid chemo. But otherwise, we need more granularity of data in that MRD negative patients who are relapsing to know which are actually these patients who are getting back. In the future, it may help us to do more active, intensive surveillance in a set of patients. Again, is this really going to translate into better outcomes for the intent to treat? We just don't know that at this point in time. But that's, again, based on the bespoke data, a promising area, which we will certainly look for more data as we go by. The outcome for patients who are MRD positive and get chemo still remains dismal, even if they become MRD negative. So there's a lot of work to be done there in terms of aspirin, celecoxib, some more targeted therapy, and so on and so forth. We just don't know what to do, but that's an area that will be very interesting to watch. The NET study, we are not happy with the way the trial itself was conducted based on the control arm, which was everolimus alone, which all of us agreed that should not be the control arm. There may be a select set of patients in whom you may want to use this combination of everolimus and octreotide, whether it's pancreatic or a gastrointestinal NET. So that's for me the carry home from the 2 abstracts or the 3 abstracts that we read. The rectal cancer abstract, I think, is not really worth it. So that's why I moved forward, because I just don't agree with anything that they have done. So I don't want to read that. We will leave it at that. Thanks so much, Vamsi. I hope people listening, are a little wiser than at the start of this panel. Thanks so much. Good night. Thank you, panelists, for joining. It was really a pleasure moderating with 3. The moderator is only as good as the panelists. If you don't have a good set of panelists, the moderator can really look terribly dull and boring. thanks so much for making it interesting. At least it was interesting for me. Once, thanks you. Thanks.
Thank you.
Thank you,
sir.
everyone. Thank you
Sir,
so
I've
much.
given my official email ID, sir.
Okay.
Sir, Amol's official email ID is his Twitter handle. I mean, you can catch him there for sure.
I am not on Twitter, unfortunately.
Yeah,
And I
that's
don't
the
intend to join. I'm not as erudite as Amol to be tweeting all the while. Anyway, good
Thank
job,
you, sir.
Amol.
Thank
Good
you, sir. Thank you, sir.
Thank you, everyone. Thank you so
Bye,
much, sir.
sir.
And
Bye.
again, I think this is a divide that is going to divide the whole of oncology community into equal or unequal halves, the pro-ctDNA and the anti-ctDNA community. I think willy-nilly we are ordering it, sir. So I think that's something which you made the point that if people get the test and come, what do you do? And at least for all the people listening, don't jump to do it unless you are very sure of all these arguments for or against it. That's how I will take it. The last part of today will be a sponsored session. This will be on HCC, and this is sponsored by AstraZeneca. And can I have the slides, please?
I don't have the slides. If you have, please.
Oh, you don't have the slides?
Yes.
I thought I had sent it to Amol. Okay, just a is this visible?
Yes, sir. It is.
Okay, perfect. So I'll be talking about advanced unresectable HCC and again discussing the outcomes with the IO drug, that is the Durva Tremi. So whenever we talk of HCC, liver cancer is a little underdiagnosed, and frankly, though it is the 7th commonest cancer, somehow as medical oncologists we see less of it for a very simple reason that a lot of the patients actually never end up with an oncologist. Unfortunately, it is still one of the diseases where you do get a lot of lymph node metastasis or spread out of the liver. In India, it is the 11th most common type and also the 8th most common type for cancer-related deaths. So again, like I said, 50% of these patients do present in advanced BCLC C and D stages. How does HCC develop? Again, a lot of data, essentially because of inflammation and immune dysregulation, either because of chronic infections or a metabolic syndrome or chronic alcohol abuse. These are the most common factors. Now, beyond these, when we look at the overall incidence, NAFLD is now becoming a much larger proportion of HCC as compared to hepatitis. Now, this is interesting. If you look at the data from all the trials of China, for example, most of them are hepatitis related. So for the CARE study, which I discussed yesterday, around 80% were actually Hep B. In the larger multicentric studies, it's around 30%, and 40% for NAFLD. And in India, right now, NAFLD is increasing quite significantly. Hep C, because of better treatment, has come down a lot. So that brings me to the management of advanced and unresectable. Updated BCLCC, which is pretty much discussed quite a lot by everybody. Essentially, it adds to the advanced stage and also includes a bit of intermediate B, where you'll be using other medicines. Presently, we have atezolizumab, we have Tremi-Durva, and we did discuss the data of Ipi-Nivo yesterday. So we have 3 sets of immunos. Now, this is as per the Western world. We do have reasonably interesting data from Tisli. We have some data from Toripilimab. We have some data from camrelizumab, though all these three are not yet approved in India. So initially, of course, we had lenvatinib, which was better than sorafenib, and that was based on the REFLECT study. Important to note that the REFLECT had a PFS doubling, but no OS. Only 1 month benefit and 13 months. This is an old study. So this is what it is. So then come the IO VEGF, I am brave. Interesting to note the inclusion criteria. They did include VP4, they did include macrovascular invasion, which is a group of patients usually excluded. So atezobev versus sorafenib, all studies are done usually with sorafenib with some exceptions. The benefit at 90 at the updated has shown that there is a 19-month overall survival versus 13.4 months for the sorafenib arm. So again, sorafenib itself crossed 1 year, atezobev reached 1.5 years. Subgroup analysis, very hotly debated since so many days. The non-viral etiology actually showed a detriment, whereas the hepatitis subset showed benefit. Again, this is just from this one trial. There was the Nature paper which said that this is logical, that immunotherapy would not work in this setting because the T cells would be depleted, therefore immuno would not work. Further studies which have shown that it works in both cases, including the paper by Dr. Anand, which said that possibly even if it is NAFLD, you do get some results with the immunotherapy. There is issues with hypertension. There is issue with proteinuria. There are some side effects with BEV. Of course, bleeding is a big issue with bevacizumab if you do not properly select your patients. So that really brings us to the dual IO, or as Dr. Senil keeps saying, the IO-IO. So IO-IO is what we are now discussing. This is certainly one place where IO-IO seems to be working in HCC. The rationale, you use CTLA-4 versus anti-PD-L1, you'll have enhanced synergistic activity. Specifically, it can reverse the T cell exhaustion and allows more activation because you're having two different blockers of the signal checkpoints. And that is why this would improve the immune-mediated clinical activity. Now, the initial study was done, which looked at the STRIDE data, that is the single high dose, versus lower dose Tremi over 4 cycles, as is done with the Nivo-EP. And they found that the single high dose had better response. And that is why the initial phase 2 study included a T75 and a higher dose of T300. And they finally came out with the result that this 300 plus Durva is the best results. And that was the arm they used in the final phase 3 study. And in that phase 2 studies, when they looked at monotherapy, the STRIDE had the median OS, which was the longest. This is study 22, and that established the STRIDE protocol. So this was the Himalaya phase 3 randomized open label study, first line therapy. Again, remember VP3, VP4 were excluded in the study. They excluded very large liver lesions. Initially, 4 arms were there. So this was before the study 22. So you had the STRIDE, you had only Durva, you had sorafenib, and you also had the 4 doses of Tremi, but then this arm was closed once you got the results of the STRIDE. So ultimately, it has become a 3-arm study. Now, based in this 3-arm study, what was done was that you gave a single dose of Tremi along with the Durva. Simpler way of looking at it. Again, look at the overall response, overall inclusions. You had viral etiology in around 60%, 40% non-viral. This is slightly different from the atezobev. It's around 30 there. BCLC-B were there, 20%, mostly BCLC-C. Now, interesting and very important is this point. The childhood A was 99.7%. So all these studies include up till childhood A only. No B7, no B8. In practice, we stretch our boundaries, but in the trial setting, as per trial, you had to have childhood A only. Macrovascular invasion only in 25% of patients. EHS was there in 53%. So again, 26% is probably a little bit of underestimation of what we see. We did have this discussion yesterday. How many patients are actually going to be childhood A without MVI or with very little MVI? And the answer was that it would be around 50% of population. So the trial settings, as in many cases, is only applicable for 50% of our patients. Now, in this, one thing which is good is that around 40% of patients and 45% of patients in the sorafenib got subsequent therapy. The sorafenib arm got 17% immunotherapy. Now, ideally, I would have loved to see at least of this 175, at least 150, 200 should have gotten immuno. We know that post-sorafenib atezobev is approved right now, post the TKI. So 17% is probably not as good as you would have wanted, but it is what it is. Now, interestingly, STRIDE looked at overall survival. Did not look at PFS, looked at overall survival. And this showed that the overall survival was met, 16.4 versus 13.8. The median hazards were significant. More importantly, this is a 4-year update, and you are having this separation, which is persistent. At 3 years, you have 30% survival, which is impressive. You have 1/3 of your patients in that subgroup surviving beyond 3 years. So that is where the real benefit of this protocol is. If you're looking at PFS 1 year, possibly not fantastic results, but as you go on, as with every IO, those who respond well and do well for a long period of time. And that's what we have been seeing in practice. Those who do well for a sufficiently long period of time. Now, again, I showed you the etiology of the atezobev, where they said that the non-viral did not benefit at all. Here, the non-viral benefits a lot. For some strange reason, HCV didn't, which I don't know. I think it's just a twist of fate. So the non-viral here definitely is showing an improvement. Tumor responses are also better with the STRIDE, as can be expected. And definitely, the median duration of response is also pretty good in those patients who respond. Reasonably well tolerated. You do have grade 3, grade 4 AEs like in every protocol. Now, important thing is the hemorrhagic, which were less. Immune mediated around 12%. 20% did require steroids. So again, this is by and large what we see in all our reports, in all our paper, in all our IO studies. So 20% is what we'll need. And hepatitis, they have not specifically mentioned it. They have mentioned around 6%. So that is, again, something which is good, that you don't have too much hepatic dysfunction. Common TREs which are attributable include diarrhea, include the usual pruritus, which we see in a lot of patients. So now Tremi-Durva has come into the category 1 recommendation along with atezobev, mainly because of the OS advantage here. Though the PFS has not met, the OS is significant, and that has now made it a preferred regimen. So atezobev has been a standard of care, but STRIDE regimen is also equally beneficial. How do I decide between the two? Honestly, both are equally good, I would say. There is a kind of a thought that you should just go for atezobev everywhere, and where bev cannot be given, like varices, that's where you should use STRIDE. I kind of disagree with that statement. Both seem to be a good protocol. Decide based on availability, affordability, and costs. That is what should really kind of decide which one to use. Durva monotherapy has been approved, but frankly, the data is not great. So I would actually go with either atezobev or the STRIDE regimen. Monotherapy alone can be an option in few cases, but typically you should try to go for the STRIDE. So that is my presentation. So thank you, everyone. And I think I'll stop here. And with this, I would also thank the organizers. I would thank Tarun and his team. I would thank all the panelists and everybody for patiently listening in for these 2 days. And I hope that everyone enjoyed the academic sessions. Thank you so much.
Thank you, sir. With your permission, sir, we can close the meeting, right?
Yeah, I already closed. You can go ahead now.
Yes, sir. Yes. Thank you. Thank you, sir. Bye. Good night.